Amazing how we don't communicate, okay? And you don't have to answer, you don't have to raise your hand, but I'll ask you the question, just like I'll bet nobody in this room has read their whole Medicare insurance policy word for word. No one does, right? Okay, so, bookie. Okay, so what happens is we all think we know what the person that you're power of attorney for wants. But I'm going to share with you two things that happened yesterday in my practice that shows you have to communicate. You can't just fill out this form and not communicate with the power of attorney that you have. But the topic was, do we need one? Okay? The reason I'm bringing this up, do you have to have a power of attorney? Okay, again, now I'm not a legal expert, but what I do know about this whole process is there is such a thing as a living will. Everybody heard of a living will? If you have a living will, you don't need a power of attorney. But, now wait a minute, I heard that, like, I got one of those, so I'm done. What is POLS? Don't just read it. Okay, it's Pennsylvania Orders for Life-Sustaining Treatment. What does that mean? You don't know, right? Why is everything so complex? Does everybody understand? So here's what I ran into. A patient, dear friend, with lung disease, requiring oxygen. 3 liters of oxygen a day, exacerbated and went to the hospital at least 3 times a year, was in a car accident after Thanksgiving, and was intubated, and she didn't want intubated, okay? But if you don't have a document and you go into a facility, they're doing everything that they possibly can. Why? Because they don't want to be sued. Does everybody understand the concept, okay? So in this particular case, this person I've known for 35 years is in that situation and was already intubated. What happened? The power of attorney, documented comment in the emergency room, I didn't know what to do. Does everybody follow the concept? Okay, so you have a document, you have a power of attorney, but it's a car accident, it's like everybody's all shook up, they don't know what to do. Doctors are doing what they have to do because they're not told otherwise. And so the patient gets intubated. And so long story short, I got called because I'm the PCP, and like I said, I knew the patient. And generally, when I have conversations with my patients that have chronic disease that are going to continue to progress, you talk about what the future may or may not hold and how you can deal with the processes that are coming in front of you. Her disease was going to be difficult at end of life, okay? And remember, that's what this is all about. This Pennsylvania life-sustaining treatment. That's the whole key here. Like, what are we doing to sustain life? Are we sustaining life? And we'll go through this whole form together so you understand. But that was after Thanksgiving. And I can tell you what I did was based on my experience, 35 years with this person, knowing her as I do, because the sister who was driving, blood in the brain, she couldn't make the decision. The other person that was listed didn't know what to do. And so what I said was, what I know of this patient is, she always said she didn't want to be a vegetable. She always said that she didn't want to have a trach and have to talk through the trach. And she always said that if I don't have the ability for quality of life, don't be aggressive. So that's what she told me when we talked. So I allowed them to stop the treatment. But why that hit me so hard was she had all the paperwork filled out. She had 2 power of attorneys, her sister and a friend. And the communication was such that they didn't really know what exactly they wanted, okay? So, we're gonna go over this form in detail so you understand, but the other 2 cases are pretty good. And one just happened last night, which amazed me. I have a 88-year-old patient that had a stroke in November. She came to me at a inpatient rehab I take care of the first week of December. And we got her back to be able to go back to her independent living with the daughter looking in on her. I'll yell if they get too loud for us. But the bottom line came down to the situation. She was still kind of alone, didn't want to go into assisted living, didn't want to go anywhere. And it turned out she ended up with what's called ischemic colitis. A portion of her intestine didn't get enough blood, so she had to have surgery. And after the surgery, she was in a declining state. Her protein went down. You're not going to get well if you don't have protein. So they put an NG tube down through her nose into her stomach in order to get her nutrition. She improved enough to come to us. As soon as she came through our emergency room, she got fussy. They gave her Ativan to calm her down. She slept for 3 days. Does everybody follow me? And the reason I'm bringing that up is you don't want Ativan. So we're going to go through all this stuff, and we're going to talk about things you need to know to make sure you give yourself the best chance for life-sustaining treatments. Everybody understand the concept? Go ahead.
We were talking about before, a patient was already trached.
Yes. No. She was intubated. They were deciding, are we going to trach her or are we going to stop treatment?
The first patient.
Right. Yes.
So after you come into the situation, so we can take that out then?
No, you can't. Once it's in, you can't take it out. What you do is you put it on room air. You no longer connect it to a ventilator that's pushing oxygen into the lung. You leave it open on room air. And the same thing happened to my family and my mother, and she lived 4 days with the tube in, and it was terrible on the family. You know, but again, and please just interrupt, guys, because this is important stuff to know. What I want everybody to understand is, once again, in this situation, what happened, I spent Friday night with the daughter, Saturday with the niece, and Sunday with the son. She had a living will. She had a power of attorney. Everybody knew what she wanted. And what happened? The patient controlled everything. Okay? Once she woke up a little bit, once she hydrated it, she said to me, "Don't put that tube down my nose ever again." I said, "Okay." And then she said she wanted oatmeal. Well, she did a test in the hospital that showed she couldn't swallow without aspirating. So what you have to do is get a waiver sign, meaning if she aspirates and something happens, the hospital's not liable. So while we were going through that, she yelled at me saying she wanted her oatmeal. So I'd already talked to the family. I knew that they were okay with that. So I brought it back. I warned her that it could go down the wrong pipe. She still wanted it. We gave it to her. She aspirated. So it went down into the lung. So she got sick. We had to give her IV antibiotics, IV fluids, but she bounced back, okay? So now I have 5 family members, because the son's wife showed up, sitting at the bedside, patients waking up, and they still can't make a decision as to what to do. And so there was a whiteboard I wrote on there, waiver, let her eat. You saw what happened when she aspirated. Second one was feeding tube down through the nose. Third one was feeding tube in the stomach. And they had never heard of it. They were in 2 different hospitals for a total of 4 weeks, and they didn't even know what a feeding tube was. So that's what we opted to do. And why I bring that up is so everybody understands. Standard of care. What's standard of care? Standard of care is what develops based on the diagnosis of the patient. Years ago, I've been doing this 32 years. Years ago, putting in a trach and a feeding tube was considered aggressive treatment. That's so aggressive. Now, it's standard of care. What does that mean? If you come in, mental status changes, and sick enough to be in the ICU, and you're not getting better on that ventilator after 4 to 5 days, trach is standard of care. Why? Because it'll help clear up what's there, and ultimately, when they pull it out, it'll heal up. Similarly with the PEG tube. Everybody that's had an endoscopy knows what an endoscopy is. They spray the back of your throat so it's numb. They pass the tube down into the stomach. What a PEG tube is, you see the light from the endoscope. I've done it. You put a little nick, xylocaine, little nick, done. 5 minutes. It's not a major procedure. Those of us that have had endoscopies know how it's done. 5 minutes it takes, it's in. What can you do with it? Everything. You can give medicine, you can give food, you can give water. It's the best tool we have for managing a chronically ill patient. And so what do? You put the PEG in for the purposes you find, usually for sustaining nutrition. That's the most important, to get the protein up. Antibiotics, medications, all that goes through the tube. And what happens? These muscles get stronger because now you're putting the protein back in. So now you can pull the tube and the patient can swallow again and eat. Why did I pick to do that on this lady? And you don't have to know that answer, but I'm telling you why. She's a survivor. You follow me? When you're in your 80s and your colon doesn't get blood and you survive that, endoscopy is a piece of cake. And I have a feeling, because I know her as well as I do, that once we get the protein back in her body, she's going to be able to swallow normal, eat food again, and I'll keep you guys posted on that. But that just happened last night. The other case that involved decision-making after the patient and the power of attorney went through what she wanted and didn't want, it had to do with blood in the brain. The patient fell out of bed, hit his head, and he had bleeding on the brain. He was also on Coumadin for his heart, so there was a lot of blood. And what happened, the patient was 77 years old. What happened was the power of attorney interpreted, because of bleeding on the brain, that this was severe, he was going to die. And so they made him what's called DNR, do not resuscitate, and CMO, comfort measures only. Does everybody follow me? Well, not only is he a patient, we're in business together. So when I heard and got the message, I went to see him. And he was at a hospital in Monroeville. And he was in there. He squeezed my hands. He kept his eyes shut, so he heard everything that I was telling him. But my point is, he had a power of attorney. He had a daughter and a son. And he had the pulse as well as a living will. And if I don't get word, I don't know if he's alive today. Does everybody follow what I'm telling you? So it's real important as we go through this, and please just ask questions as we go through to make sure everybody understands what we're talking about. But those, and I didn't expect last night's story, but those 2 cases hit me that, wait, all the paperwork's done, all these things are completed, all the people are in place, and it still happens. Why? No communication. No one wants to talk about death and dying. No one wants to talk about end of life. You have to, and you don't have to tell your PCP, you don't have to tell some other, professional, but you have to have somebody you trust. And then as we'll go through it, you have to have an alternate. Because believe it or not, even if you're 20, 25 years older than your power of attorney, they can leave the world before you do. And if you don't have that alternate, then you're making all those decisions when you don't want to. Okay, so everybody with me so far? I had to set it up so that everybody sees what we're talking about and why, because I see the bad side. When I say the bad side, there should be no suffering, ever. And what's funny, not funny, sad, the patient that agreed to the peg tube, the daughter and the niece were like talking aloud. And she said, "What are you talking about? I've had 2 endoscopies." So to me, she knew exactly what was going on. She understood the procedure to get it done. And she recognized that when we pulled it out, it would heal up and not cause her any problems whatsoever. Once again, communication, listening to the patient. And you want to do that when you're alive and well and comfortable and cooperative and you can do everything. But what's interesting is, the one thing I'll tell you you can always do with these, change your mind. Does everybody follow me? I have to tell you the reason that the pulse was invented. End-of-life Medicare patients spend 85% of the benefits they used in their Medicare system. That's why it happened. They no longer do stand up in the morning to talk about the sick patients in the unit. They do stand up for length of stay. And for those of you that don't know length of stay, before you go upstairs from the emergency room, it's already decided by your insurance company how long you're staying. Okay, does everybody understand the concept? So with all these things put into play, I'm letting you know where healthcare is going and what you have to do. All right, we'll see. I think I'm spelling it right. Anybody know what a doula is? Anybody heard of it?
It's childbirth,
Pardon me?
something with childbirth.
Ooh, I was going to give the second hit. OBGYN. My wife's a neonatologist. She trained at Cornell. And when I went up to visit her while she was doing her fellowship, there were 70 babies on the floor. All 70 fit in my hand. It's a remarkable experience to see something this small grow. And they used to have picnics, like 5-year celebration of the preemies and all that stuff. And it was amazing because you'd say, like, "Man, I held you in my hand." They're like, "Get out of here." I said, "No, you were in my hand." And now the guy was like this tall. But my whole point to all this is, it started babies were being stolen. My wife worked in New York City, like I said, and she did the first research on crack babies that were born to crack mothers. And while she was doing all that research, what she identified was no one pays attention to the baby. You know, on the board, it's a Y or an X in a room and who the doctor is. There's no names, there's no anything up there. And they put an armband and they get your fingerprints and they get your footprints and all that stuff. But no one watches the babies. They take them back and forth to the nursery. But you'd be surprised that when I say watch, I'm talking about like the hall patrol when you were in school. Someone stood in the hall and made sure no one came out. So again, not just because of this, but because of the whole, from pregnancy to delivery. Lack of communication. And I remember my wife telling me about it over all the years. And she said they finally did it. We have doulas. And I said, what the heck is a doula? From the time you're pregnant till the time you deliver, This person takes care of you through the whole pregnancy. They make all your appointments, they go to all your appointments, they do all the follow-ups, they go to your office visits, they interpret what it is, and the statistics are phenomenal. I mean, I couldn't cite them because I'm not a neonatologist, but like I'd say something that went from 25% that you saw it occurring is down to like 3%. And that's with outcomes, you know, so just the mothers not being stressed, I mean, we've all seen healthcare change from the vantage point. I had a personal friend that was my resident, and he said, one thing you want to do is anytime your patient gets admitted to the emergency room, go see them. I said, what do you mean? If it's 3 o'clock in the morning, go see them. I said, well, that's what the ER doc's for. And he said, I'm telling you, go see them. And it makes you feel the passion of medicine when you see someone scared. Half of the curtain open just so that they can peek out. And all of a sudden you come around the corner. Face lights up. Now they know somebody. Now they're going to know what's going on. That's what the doula does. And so what occurred was they followed these babies and they saw such an improvement in outcome. And improvement in expense. So along comes life-sustaining treatment. And I have to be honest, and for those of you that are my patients, you may know I might not even have a pulse on you today. Because I didn't like how it was pushed through. It seemed to be more of a financial thing than anything else. But now that I've seen what happens and the stress that occurs, people don't get admitted anymore, they get stuck in observation, all the changes, more than ever, you want to have a communication with whoever your POA is and understand the things we're going to talk about today so that they know exactly what to do. Because once again, these friends of mine didn't know what to do when Denny fell on his head and had blood in his brain. And no one at the hospital explained that'll all absorb, he'll be okay. So they're thinking like, uh-oh, he's gonna die, you know, so let's make him DNR. And no one explained that. That's why I'm talking to you today. You have to understand this stuff and definitely have a conversation with your PCP and whoever your power of attorney is. Not quiz them, but talk about stuff we're gonna talk about today. You know, what happens if I fall on my head and I get a bleed in my head? You know, or what happens if I break a hip? Or what happens if all of a sudden I have to have surgery on my abdomen? You know, what happens if when I fall down the steps, I'm now having to go to rehab and it's gonna take 6 months before I get back home? Which of course, everything I'm telling you is realistic. If you fall and break a hip, it's a lot different than if you go in because it hurts you. So if you fall and break a hip, chances are something else happened. I'll give you another example of an admission I had. 32-year-old patient that works as a oil rigger, they call it, and something they have to do. The pressure got so high, it pushed him backwards, crushed his chest, crushed his spleen, ruptured, pushed on his pancreas, shut down one of his kidneys, and busted his right knee and his right ankle. And fortunately, someone saw it happening and pulled him out, because it would have kept going and he wouldn't be here. But once again, he didn't understand any of his options despite having a pulse. So please make sure as we go through this, raise your hand if there's questions. All right, so everybody has a form? Can everybody see this? I think it's good enough we go through it that way. All right, remember what it is. Pennsylvania physician orders for life-sustaining treatment. So, shoot.
I'm a long-term care nurse.
Okay.
Years ago, and now I don't know how the law has changed, but if you had a patient that came in and became unconscious, and that right away they put a feeding tube in,
Okay.
it would take an act of Congress to get that feeding tube out.
Sure.
Is it the same now?
No, now this actually helps this. I have to say there's not a whole lot of things that this does, but that's one of them. This is related to life-sustaining treatment. So what you put in here, they would be able to pull it out. You know, your power of attorney would be able to come in and say, you know, Mary didn't want to live like this. This is not the way she thought she would have the rest of her life. So I'm the power of attorney. Please pull that tube, and they have to pull the tube. Because you would then have legal, in Pennsylvania, you're the legal representative of her because she can't make decisions for herself.
And I had a patient who lived like 5 years.
Sure.
That feeding tube, and she
Sure.
was full for 5 years.
Well, but there's some good ones too. I have to tell you guys a good story. But I know I was late, so I only get one story. There was a patient here whose father was a judge, a well-known judge. No, his son. Son was a judge, well-known judge, still practices downtown. So I took care of the mother and the father. The mother passed away, and here the father had a stroke, and it left him with what's called dysphagia. He couldn't swallow. And so he kept aspirating and getting pneumonia. And one time he got mad at me and he says, why does he keep getting pneumonia? I said, because these muscles are too weak. Well, how do we strengthen them? You got to put a feeding tube in. And he goes, what? And he made me meet with, I forget the guy's name, Judge O'Connor, I think. So the three of us had lunch together, and they made me make the case that this was the best thing for his father. And I didn't budge, because again, I've had the guy for 20 years at that point, and he's a survivor. You base it all upon the person. You know, if you have someone that's strong-willed and they have the ability to get through these things, you never blink. So I told him, I said, yeah, I think your father would do great. I think that once this clears up, he'll no longer have pneumonia. Will he be able to get the tube out and swallow again? I said that, I think he was 90 at the time. I said that remains to be seen, but I can tell you his lungs will clear up. So long story short, he lived another 7 years. They went to church every Sunday together, and he started to get dementia pretty bad, but the first couple years he was able to communicate. And once again, that's why I'm telling you, trach and tube are standard of care today, depending upon the severity of your illness. If you come in with a bad MI, if you come in with a bad pulmonary embolism, if you come in with something that requires surgery, you're going to the ICU, and while you're in the ICU, most times, I would say probably over 85%, that gets done. If they're not going to be able to extubate you, trach. Tube goes right away because it's so simple. You're able to give medicines, fluid, anything you need through that tube. And once again, when you leave, they pull it out, it heals back up. So please keep that in mind. All right, so everybody has their form. The top one, A, this has to do with resuscitation, okay? And your choices for that is resuscitation and CPR, and the other one is do not attempt resuscitation or DNR/no CPR. All right, things to say about CPR. First and foremost, most every place now has the equipment that kind of does it by hand. You know, they put this over your mouth, and there's even things they can put on your chest to do the compressions. Years ago, if the person was compressing hard and you were thin and frail, there could be fractures. Other than that, nowadays, that's so less than, it's like minimum in terms of risk. Once again, it comes down to you. If you're healthy and you have no problems, CPR has saved many, many, many people. So it's something that you have to take into account. Talk to your PCP. If you have bad diabetes, bad heart disease, bad kidney disease, bad liver disease, remember what I'm saying, bad. What does that mean? You're seeing specialists on a regular basis to monitor the function of that organ or the multiple organs, then that's something to consider. And what you put in there is resuscitation, and then you put a line in there, don't do this, don't do this, don't do this, don't do this. Does everybody follow what I'm saying? Those two there make it look like you just have to check one or the other. You're allowed to put in there resuscitation, and then you put a little asterisk, and then you put it on the back of the paper. So say you don't want intubated, or say you don't want shocked, or let's say you don't want full compressions. Those are things that you talk to with your power of attorney so they know, and ultimately you modify. That's why there's extra paper, you put that on the back. So you don't have to. Remember what I said, you could change your mind. I've had patients say, if I ever get cancer, I don't want treatment. And then they get cancer. And as they start through the process, they'll say, I'm still not treating it. I don't want to go through that chemo. I don't want my hair to fall out. I don't want these things. And then all of a sudden, the doc checks them and it's gotten worse instead of better. And then they change their mind and they take the treatments that's out there. So my whole point is, this isn't a document that can't be changed. You can change it while you're in the hospital. Because they'll come to you and say, you know, Mrs. Smith, we see you have a pulse that was signed by your power of attorney and yourself on January 16th, 2025. And you say, yes, but I don't want to follow that. You have that right. Now, if they say you're incapacitated, you tell them, you call my power of attorney. And your power of attorney will understand. That's why you have to communicate. You have to talk about the things we're going to go over. Because it happens in a blink of an eye. You're wonderful, you're driving, you're doing well, and all of a sudden you're looking up and you're seeing faces in front of you and you're in an ICU and all you're hearing is bells and whistles. Okay, so everybody understands. On that first line, resuscitation with CPR, and what that stands for is cardiopulmonary resuscitation. And then the other one, as we stated, is do not attempt it. And once again, I have patients that I didn't agree with them, but I followed what they said. When I first started back in 1990, people didn't trust doctors. They didn't trust hospitals. Most of my working guys, like the bulky guys, they'd even say it. No, I'm not going to that hospital. My mother died there. Or I'm not going to that hospital. Uncle Fred died there. And I had patients that were strapping guys. The technology was out to open up those arteries that they could have lived another 20 years. And they would say, nope, I'm not doing it. You know, so it's up to the person what their wishes are, but whoever your power of attorney, remember, pick an alternate. All three of you sit down together, and we're gonna go through more, we talk about it. And at least you got this, because every time I say Karen's gonna do something, we don't get it done. I'll make sure we get some information out so we follow up, guys. All right, now the second one, medical intervention. Uh-oh. I started to get to the point I gotta get my cheaters. Medical intervention is a good one to go over because a lot of the things that are on here, you don't know what they are. And so a lot of times you'll say, no, I don't want that. But in reality, it's something that you always have the choice of changing your mind. Remember that. All right, remember what I said, CMO? DNR and CMO, comfort measures only. What does that mean? If you have any wounds, they move you side to side and position you. If you're having pain, they give you pain relief. If your oxygen is low, they give you oxygen. If you have lung disease, like I was telling you about the one patient, and you have a lot of mucus, then they suction through the airway. But what's on there that you want to pay attention to is do not transfer to hospital for life-sustaining treatment. Transfer if comfort needs cannot be met in current location. All right, that's there. You have nothing to worry about. I've been here forever, and you got good staff up there. But there are nursing homes and places that aren't so good. And there's a lot of different places that just will get you out. Like if you're carrying on at night and you're disrupting things, if they see one day you're urinating more than normal, they send you out to the hospital and say urinary frequency. But the bottom line is make sure you pay attention and talk to whoever your power of attorney is. When this says do not transfer out of the hospital for life-sustaining treatment, if you have an advanced cancer, if you know that you do not have any hope for survival, that this is going to progress, then that's a fine choice. But you don't want to check off something like that just because, like my buddy that bled in the head and everybody thought he was going to die because he had blood in his head. You don't want to just check this off because you think you have to. Understand what it's saying. You know, you're here. You have nothing to worry about. You hit one of those chords, someone's going to come run and see how you're doing. And generally, I think everybody knows everybody. So I think that there would be more attention paid to you, but make sure, once again, you pass it along to friends and family. Because those two lines in there I never liked. You know, because I go to nursing homes, I go to a lot of different places. So it's something we want to pay attention to. All right, the other one now, this is good. This is the one, I gotta put my cheaters back on to read that fine print. This is the one that allows you to make definitive statements regarding what you want and don't. So underneath the comfort measures only, the limited additional intervention, use medical treatment, IV fluids, cardiac monitor as indicated, do not intubate, advanced airway interventions or mechanical ventilations. So that would mean that if you had lung disease pretty bad, or if you had pneumonia related to other diseases that you have, and you did not want to have these tests, these situations done. That is, you didn't want anything advanced such as cardiopulmonary resuscitation, but you definitely wanted to get IV fluids, have them keep an eye on your heart. So that limited one, you would talk to your power of attorney and go through specifics. And it would be related to whatever disease you have. If you have heart disease, if you have lung disease, if you have bad diabetes, if you have other vascular disease, if you've had any organ disease such as hepatitis or pancreatitis, those are the things that you go over specifically with your power of attorney. The bottom one, full treatment, is just as it says. You go through the doors and you allow them to get you well. And again, guys, my best story, and you guys may know him, and he's passed on, but I always promised him I would talk about him. I get one more story. I laugh. Angelo Camerata. The place was called Cam's on Center Avenue in Westview. Angelo was 100 years old when I filled out the paperwork for him to get his license back. It was a day like today where it was snowing. He left his house at 8 o'clock, drove down to the Unimart. It wasn't salted or cleared. And he slid into the cement post and it bent his tire. He called AAA, he called his insurance man, and he called his mechanic. Then he went in to get his groceries. He comes out and there was a cop writing him a ticket and took his license. Okay, so he came to me and I said, you did everything you were supposed to do. You didn't do anything wrong. And he goes, yeah, but they'll never give me their license. I said, no, Department of Transportation's love seniors. Let me repeat that. Department of Transportation's love seniors. They know if you lose your license, that's your independence. And they take good care of you. So he came in, I examined him, we had a conversation. He got his license back and he went down to the police department just to show the cop that he got his license back. But anyhow, the story I talked to about Angie, he calls me up. When he turned 100, he was still in the bar. So he was the oldest bartender in America. So he calls me up, he goes, hey, we going to New York or LA? I go, Ants, what the hell are you talking about? He goes, I can go on the Leno show, or I forget the other guy's name. He was on Channel 2 at night. It's way back. Either way, he's asked me about both. And I said, well, I got a guy that lives in Burbank, you know, and he's been on the show before. He said, okay, we're going. So we make plans. He calls him and says he has to bring his doctor. So we make plans, we're going. We were on for a Friday night, already had the tickets. He gets called on Wednesday. And he said, we got bumped by Ellen DeGeneres. But Angelo was amazing because he knew what he wanted. And he said, Doc, I'm 100 years old, I'm still working. I can't live forever. You're my doctor. When you see that it's not going to get better and it's broken, just make sure that my wife doesn't suffer. He didn't say him. He said, make sure my wife doesn't suffer. I go, what do you mean? He said, even if I'm in a severe pain and doing terrible, you tell her I'm fine. I said, okay, Ange, hopefully we don't have to lie to your mom or your wife. All right, now again, guys, remember, full treatment, do not fear. That's the other thing, like I told you. And I can speak to my father. My father had a ruptured aneurysm, and they had to emergently operate on him. He ended up with a trach and a tube within 4 days of being in the hospital. And he could still talk, he could still communicate. He wrote stuff, like he'd whisper, but he'd write stuff to you. And he was in the hospital, that in the LTAC, it was like 7 or 8 weeks. And then he finally went home, got back to driving, doing everything. He wore regular shirts, like there was a little scar there you could see, but it all closed up nice and there was nothing on the belly. And so once again, I'll never forget that day. The girl who was taking care of him called me up and said he was having testicular pain. And that's a sign of an aneurysm. So I said, I'll meet you in the emergency room. So we go to the emergency room and the doc calls me out and he goes, it's gonna rupture. And I said, how much time we have? He said, I don't know. And I said, well, let me see what he wants to do. So I go in and I tell him the story. He goes, well, I'm here, we might as well get it fixed. And while I go out to tell the nurse yes, he codes, like eruption. So long story short, you never know, that fast everything could change. And it took him 6 weeks to get back home. But the point that you have to understand is, what is full treatment? Full treatment is what we call standard of care. And what I told you about a trach and a tube, when I first started in 1990, people, that was, no, I don't want a trach, I don't want a peg tube. I'm telling you now, both of those things are very, very good to get you from point A to point B, because everything can be done there. Fluid can be put in there for you, food can be put in there for you, all your medicines can be put in there for you. And that takes away from you having to fight through the weakness that you're gonna have. Plus the nutrition that you can get from it is remarkable. And they can do it while you're sleeping at night. So it all works out, so don't fear what these treatments are listing. All right, you guys ready for the next one? C, antibiotics. Amazingly, after all this stuff happened, my father did make it home to my sister's house. And long story short, he ended up with a urinary tract infection. And let's just say miscommunication, it took his life. So somebody that survived a ruptured aneurysm dies from a urinary tract infection. Okay? Why do I bring that up? Antibiotics are very important. We call it, if you spike a temperature, if you have a change in your mental status, or if your blood pressure, your pulse, your temperature, these things change, it shows something happens in your body. So what we do is we call pan culture. That is, you culture everything. So you culture the blood, you culture the urine, you culture the throat, you culture anything that can be cultured, because you're looking to see what's causing this change in the patient's condition. The other thing that you do is start antibiotics prophylactically. What does that mean? That means something's going on. And in medical school, we learned the 4 W's. Wind, lung. Wound, on the body somewhere. Water, urine. And then whatever. If you get to the whatever, you got to think of all the possibilities. But the bottom line is, you start the antibiotics as soon as you get the cultures. Because if you do the antibiotics and then culture, you're not going to get a good culture. But the bottom line is, that takes minutes. So they call me up, Dr. Coppola, so-and-so has a temp of 101.7, what do you want to do? Culture everything, get them started on Rocephin and vancomycin. There's things that are called gram negatives and gram positives. That's how we identify bacteria. By giving you what we call broad spectrum antibiotics, anything that's in there, it's killing. So when you see antibiotics, don't ever let anybody tell you that those can hurt you or harm you. Now, once again, if you were somebody that was having problems with antibiotic, ended up with what's called C. difficile because of the antibiotics, then you change it. But if you check in there, yes, you want the antibiotics, you will get those antibiotics as standard of care if something's going on. Because if you go in and you can't talk to the doctor and your power of attorney isn't there right away, they're gonna read this list and come up with that choice, okay? Underneath that was artificial administrative nutrition, okay? That's back to the NG tube or the feeding tube. And once again, everybody thinks of that as horrific, that, okay, we're doing this, so that means I'm dying. No. That means that the connection between your swallowing and your stomach is impaired, or your illnesses have caused your protein to go down. You can't catch up your protein. They'll give you, the protein shakes, the Ensure, all that kind of stuff. You can't get it back faster than they can by putting it directly in your stomach. Okay, so what does that mean? 2 ways to get to the stomach. NG tube. Is it comfortable? No. But it's the easiest. So generally what will happen is if you come in and you have mental status changes, you're going to get the NG tube to have access down into the stomach. Unless you mark on here you don't want it. And I'm here to tell you, my mother had it, my father had it, friends of mine have had it. I've actually put them in patients before just to get the process started quickly. And especially the NG tube. You pull it out, nothing to it. However, it's not pleasant while it's in. I'm not suggesting to you that, boop, we put this in, everything's wonderful. It's a PIA because you bump it, you knock it out, those types of things. That's why I go for the PEG tube. And once again, it's an endoscopy. They spray your throat. They may give you a sedative if you're a little anxious about it. The tube goes down, 5 minutes, the PEG is in, they're done. It's faster than an endoscopy because all they're doing is shining the light. You make a nick, you put it in, it's done. It's not a major surgical procedure. When you don't need it any longer, you pull it out and the abdomen heals up. Okay, so again, what's the artificial nutrition? As it says there, no artificial by tube, artificial nutrition. Second one, define trial period of artificial nutrition by tube. What that is, that's what the lady I was telling you about that we were trying to come to what to do, and I finally told her to do the tube feed. She had it in the hospital, and whatever happened in the hospital, she just was so adamantly against it having been done again. So maybe it came out, they had to put it in. Whatever the experience was, she wanted nothing to do with it. So we were either pleasure foods, which the family opted. We tried. I told you she aspirated. She didn't want the NG tube. So that leaves us with, when it says long-term artificial nutrition by the tube, that's one of 2 things. You keep that NG tube in for a long period of time, or you put in what's called the PEG tube. And once again, guys, I'm here to tell you, I haven't had it personally, but I took care of my father when he had his. I took care of my mother when she had hers, the patients I know. It's not painful. It doesn't disrupt anything at all in your body's functioning. And once again, it's standard of care today. If you go in and you can't talk for yourself, or your blood pressure's down, or you're having a heart attack or whatever, that's standard of care to put that tube in. So please make sure you understand that as we move forward. All right, so now the bottom of that says summary of medical condition and signatures. Patient, parent if you're a minor, healthcare representative, court-appointed guardian, and then other. Once again, what I would do is have your medical power of attorney sign it, but then I would put a little asterisk on there, and then on the back, please get an alternative guy or alternate. What happens is, it's amazing. Some people, for whatever reason, diabetes, I'm seeing a lot of problems, mostly because of fructose corn syrup. But I'm seeing diabetics check out early. So say you're in your 80s and you get somebody that's 60 years old and you think everything's going to be fine. If something happens to that person, you're now without a representative, and that's a PIA, especially if they say to you, are you competent? Because then you got to go see a doctor, do a competency test, all those kinds of things. So if you have an alternate on here, it automatically, if something happens to the original power of attorney, the alternate is automatically there. So it's something, again, guys, I see when it's a PIA for the patient. I see when these things happen, and then they got to go through the changes, and they're not saying I'm competent. Can't you say I'm competent? You have to see a psychiatrist, like it's a whole rigmarole. So that's why I'm making sure you see that when you put down on there, you sign this paper so it's a document with your power of attorney, but as soon as you can get an alternate, you put that right on the same page and date it and put your initials on it. And it's a document, guys. And again, I'll make sure we get the pink ones for you guys. I'm sure Karen had it. I don't know what happened. The fact they copied all this, we probably just didn't have enough of them. But I got a whole bunch of them in the office. But you want to fill that out. Do you need a living will? No, if you have this done and you trust the person and you have an alternate. Is a living will binding? Yes, it is. Even if you can't speak for yourself, you can design a living will, which is in more detail than this, but it goes through the scenarios that can happen. And yes, you don't have to be alert and awake and mentally competent. That living will tells what you want, and they have to follow it. And I also have to tell you, I do get calls from my patients. Not my patients, wherever they happen to be. Like say they go to a hospital in Florida. I have a lot of like snowbirds. I've been called from Florida before, like, hey, we have Mrs. Jones here, you're listed as the PCP, husband isn't around, we need to do something now or not, what do we do? And that's another thing that does happen. So your PCP does get contacted no matter where you are in most cases. Sometimes it could be such a tragedy that they have to make a decision immediately, and that's gonna go with, do you have this power of attorney? I'm gonna talk to Karen again because what I've done in the office, I had some senior patients ask if there was any way that they could get this made into a card. And the answer is yes. So you can end up having your insurance card and hand them the card of what you want. So that way, whatever the packet is. And I'll talk to Karen about that because it's real simple. It's not a long process. And then I tell people, put in your PCP, put in your cardiologist, put in your neurologist, put in your psychiatrist, put in your orthopedic. And they go, I don't have one of those. Well, if you don't pick a name, here's what happens. You come into the emergency room, here's where the doctors pick up the chart. If you walk in and you don't have a doctor, it goes under house. What is house? Residence. Is that okay? Sure, they all have to learn. But you pick a name. Find out with a friend if they have a cardiologist who it is. Well, I've never seen them before. Trust me. If your card says you see Dr. Smith, you're going on the Dr. Smith pile. And if someone calls and they say, Dr. Smith, we have Mary Jones in the emergency room, she says you're the cardiologist. Oh, I don't see her on my list. I'll be down in a minute. They never, ever, ever turn away patients. You follow me? So I'll talk to Karen and see if we can get you that list. What's so important to me though, guys, is all the stuff we just talked about, you have to make sure that your power of attorney understands what you want and what you don't want. I have a lot of patients that said they had diabetes, they didn't want to lose a limb. I don't ever want anything cut off. Well, what that comes down to is the only reason we take limbs off is because they're infected or they don't have a blood supply and they will be infected. So if the recommendations by the surgeon and your vasculature is such, you have to have it off. So have that conversation. If you're a diabetic, no one wants to take it off. We hope no one loses anything, but it can happen. And so you have to make sure your power of attorney is aware of, hey, if I have complications related to my diabetes, see what my doctor says or see what my endocrinologist says. If they say it's bad, then I don't want to go under XYZ. I don't want to have my whole leg taken off, or I don't want to have up to the knee or above the knee or below the knee. All those things you have to talk about. The other thing that's big is, what if you get dementia? Okay? That one's a tricky one. Because what happens is the spouse, the significant other, or the caregiver of the patient is the patient. Does everybody follow me? To be a caregiver of a demented patient is very, very difficult. The person I was telling you about that fell on his head and got some blood, he had COVID, fell on his head, and when he was in the hospital, he got the antibody and some other things, and his memory was a little bad. Now it's real bad. And we had to put him in my personal care home because his wife was mean to him. I know her well, I've known her for 40 years. Not mean, but when you're taking care of somebody, you know the routine you have to have in order to do what you have to do. So he ended up peeing his pants. We were in the living room, and she literally threw him on the couch, pulled his pants off. Like, she did it because they were walking out the door. She had to get this done. I didn't see anything that was mean or malicious, but watching it, one of the first things he said when he went to the personal care home, he goes, "Boy, it's nice to have somebody take care of me." And of course the wife was livid because she says, she's standing there, "Who do you think's been taking care of you for the last 6 months?" You know, so it's a patient has a certain understanding based on their dementia, and the caregiver is cooking all the meals, making sure they get to bed, changing the diapers, doing all the things that have to happen, and it doesn't stop. It just goes like this. And that's why I finally convinced her to take him to the personal care home. And she's like, "No, he's gonna hate me. You know, I don't wanna put him in a home, all this." I said, "Look, it's wintertime, he can't do anything, just put him up there." He's having a blast. I see him all the time. We were watching football over the weekend. You know, they're coming and waiting on him. You know, he gets to go down, he has a menu he can pick from. He's fine. But the bottom line comes down to, you have to talk. You have to communicate. I can't overemphasize the communication, guys, because it happens in every realm of healthcare today, unfortunately, because of the changes in healthcare. You know, back 30 years ago, mistakes weren't made the way they are today. And it's unfortunate, but it's true. Remember we started with the doula? These are men and women that take the pregnant patient all the way through to delivery and make sure that baby gets home, and then even follows up at home. And I think you're gonna see that happen in medicine. It's already happening. What do they call it? They do it in oncology. I forget the word. It's not doula, but what happens is the cancer patients, if you don't follow them around and go to all the appointments with them, sometimes they don't feel well, they don't show up, say, to radiation treatment, and they miss a couple days, so now they're behind, and then trying to get caught up, they miss a chemo, and before you know it, they're so far behind, it upsets the apple cart. So when you have this person that comes along and guides them through it, everything's perfect. And it's usually a nurse or somebody that knows the community so that you can help out. So you can call the hospital and say, "Hey, Mrs. Jones needs to have a chest x-ray. I've been taking care of her for the last 10 weeks. Can we get her in? We think she has pneumonia." Adding that from a nurse that worked in the hospital, she's gonna get that chest x-ray. Versus the home care person that just comes in, it's gonna be a different person the next day. You guys don't have to worry about it, but I'm just throwing it out there so everybody understands. The system cannot handle the current need. And so what they do is just push everything back. I mean, I have patients waiting 3-4 months to get their gallbladders out. I have patients waiting 2-3 months to get an MRI. You know, it's just the nature of where it is. So once again, guys, the most important thing to this form is communication to your power of attorney. Let me just go through 2 more scenarios that you have to think about because they happen. Uh-oh, I stole his pen, I don't know where I stole it. There it is. All right. Infection. Over medication. Okay? This one I put first because remember what I said about the antibiotics? I've done a lot of stuff over the years since I've been in practice, and one of the places, they're called LTACs, they don't have them, many of them anymore. But what that stood for was long-term acute care. What does that mean? Well, the system says the length of stay, you gotta be out of the hospital in 4 days. Well, you're not ready to leave because you had open heart and now you have an infection on your chest. So they send you to a long-term care facility. I'll tell you one thing that maybe can make its point so I don't have to beat it up. If you wanna go to a hospital and work, You have to have experience or have just come out of a program to be able to get in. Follow me? You can't just show up and work in the hospital if you just graduated on Monday. You can't start that job on Friday. In a long-term care or LTAC, you can come right out of school and get in there. Okay, so not a lot of experience. So you get high acuity patients with not a lot of experience staff-wise. And so what you end up with is you're in situations and people don't understand infections, okay? Infections are a change in whatever organ is involved. We'll go back to my 4 W's. Wind is the lung, wound is the skin, water is the kidney. Or of course it could be a UTI, all right? Skin is the largest organ in the body. What I find, especially when I take students around, and I'll tell them, okay, examine the patient, and then I'm gonna come bedside with you, we're gonna go over the patient. And it's unbelievable, guys. You'll finish up and you'll say, okay, how's the backside look? Oh, we didn't look at the backside. That's where the wounds start because of the pressure on the backside. And that's one of the places that can cause the infection. And if there's not too much, no matter how big your backside is, there's not too much space there. And once that skin breaks down, that can take a long time to improve. So why, again, I emphasize the antibiotic. Infection could take your life rapidly if untreated and unnoticed. And that's why what you want to make sure of, whoever you're talking to that's your power of attorney, skin. How is the skin? It's a very important question to ask. If the skin is broken down anywhere, first thing I think of is protein. You're not eating enough, your protein's too low. You gotta get that protein up. But that's an important part of the power of attorney, knowing your body. They don't have to be examining your body, but knowing your body. If they know you have no skin breakdown whatsoever, the first question the POA wants to do is, how's your skin? Because that's a big problem that we run into, especially if you're confined to the bed, okay? This over-medication one, the patient I was telling you guys about, the daughter's a medical assistant for a practice in Moon. And she indicated that her mother had bad pain in her GI tract, took her to the emergency room. They found it was ischemic. They did the surgery. She was in the ICU, and someone gave her Ativan because she was getting rowdy. And it took 3 days for her to kind of wake up, but she woke up. And she was talking, she was interacting, she was doing fine. And then they transferred her to the regular floor. And what they do is they put the tray down. And then someone comes back and picks it back up. So they don't pay attention to the detail of what you ate, what you consumed. Back in the day, we had to watch and see, did they eat everything, what percentage, and they listed that. So what you can run into, and what this lady ran into, was her protein went down very, very low. When she went to the regular floor, they gave her Ativan again. 3 days she was down. When she came to us, she woke up, but by then she couldn't swallow. She was so weak, her protein was 4. Normal is 7. And before she went into the hospital, she was 7.8. So that's how fast it goes down if you're not eating. So once again, guys, what I overemphasize is over-medication. So your power of attorney needs to know every medicine that you take and why you take it. And what you'll find is very, very simple. Go to your PCP and have your PCP print out your list. And that way you can see all the medicines and go through with your PCP. What am I taking this for? What am I taking this for? And you have to be able, with the PCP, to understand that well enough so you can tell your power of attorney. So you have to tell your power of attorney, oh, I'm taking this omeprazole for the reflux that I have. I'm taking this amlodipine for my high blood pressure. I'm taking this Lipitor for my high cholesterol. I'm taking this Jardiance for my diabetes. You have to know your body well enough to communicate that to them. or at least tell them, pay attention to my medications. Because again, guys, in the hospital, because they want, I hate saying it, but it's true, they want you out. Like, they don't want you in there, that bed, they don't want you taking up that bed for more than 2 days. So they get you from where you are down to another floor. The communication that used to happen doesn't happen. So you come down with a med list of what you're on. And they get a report from the doctor that discharges to see the state of the last exam on the patient. And so now you embark on a new floor, new aide, new nurse, new everything. Therapy usually comes in. Long story short, what happens in that period of time and what you don't want to have occur is more medications. So you compare what you're taking when you went in and what you're taking when you're going out. And follow up with your PCP. They usually make you do that within 3 to 7 days. But if that happens to you where you're hospitalized and you get out, get into your PCP and make sure you review the medications. Because what I find a lot of times, that's a big problem. Like this patient I was telling you about, it's a real quick fix for the nurse. You know, the patient's yelling out or screaming or whatever, she's got other patients, the floor's disruptive, they give them the Ativan, they're out for the day. Unfortunately, even the next day. And so what you run into is be aware and talk, guys. You have to talk. Please communicate, because otherwise you run into situations. Okay, last one I'll leave you with. Know when to stop. I told you about the patient that I had them stop the ventilator. Did it with my mother. It's not fun, but you feel good afterwards because you know that's what they wanted. You know they did not want to live with the ventilator, or you know they didn't want to live going to dialysis. Or you know, and again, that's a good one to bring up too. Dialysis isn't necessarily forever. Small percentage, get off of it, but it's all related to the disease. If you had no kidney trouble, all of a sudden you have a bad disease, your kidney function declines so much that they have to filter everything through a dialysis machine, that's not necessarily bad. It doesn't say you're gonna be on it forever. So once again, power of attorney needs to know your thoughts related to dialysis. And I again would recommend you talk to the doctor, who they call them nephrologist. Your power of attorney has to ask, can she get off this dialysis? And if it's something that they're confident that you can, they'll tell you, oh yeah, this is interstitial nephritis, it occurred because of the antibiotics she was on, or this was related to obstruction, it's all gonna clear up, I think we'll be fine. Or if they say, I can't tell you for sure, make sure you talk to the patient if you're the power of attorney, and make sure that if you're the patient, you talk to the power of attorney. Do you wanna be on dialysis or not? Those are the big ones that we run into. Trach, tube, dialysis, and then again, guys, the big one from my end of it, when is enough enough? I told you, I knew this person 35 years, and I knew because she was my patient, and not everybody, I don't want to scare anybody that has lung disease. A lot of lung disease patients go to sleep and don't wake up. But sometimes it's a very difficult road to hoe at the end of life. And so once again, when do you stop? Have that conversation with your POA. Like, hey, if I don't have quality of life, if I'm not doing things that I enjoy doing, if I don't get to see friends or family, if my mind is going to the point where I don't even really know who you are or what I'm doing, don't be aggressive. You know, but that's in your heart. I'm just throwing it out. Yes?
Okay, I want to make sure I understand this now.
Sure.
If I'm a patient,
Mhm.
and I say, okay, you can do all this aggressive stuff, and the doctor says, okay, she still has a chance to make it, but I'm tired, and I don't want to do it anymore. I am legally, okay, I mean, now, they will
Sure.
need to say, I want to stop.
If you're competent and your mind is fine, yes.
And
And right now, what you wanna make sure of, based on that, the comments, your power of attorney knows that. When I say enough is enough, enough is enough. And if I can't say it, enough is enough. Like,
If my power of attorney.
yes, and they have to shut it off.
Law will abide.
That's what it is. Pennsylvania orders, that's what this whole thing is for life-sustaining treatment. You have control in your hand of that form. And so you tell your power of attorney that if I'm ever at the point where I'm just tired of this, I don't wanna do it anymore, and I let you know that, you tell them I'm done. Or if I'm out of it, that means I can't say I don't want this anymore. Explain, and they'll know you. I mean, you wanna pick someone you know. And so they know you. So if you have somebody that knows who you are and how you are, and they're coming in and seeing, boy, this isn't Mary that I know, and Doc, is she gonna get better? You know, be there, ask some questions, those types of, and they'll call you back. It might be their physician assistant or nurse practitioner, but the doc will call you back, especially in an ICU, CCU, or the critical care units. But great question, because you're still in control. And don't forget, I'll leave you with this one. The back of your Medicare card has a 1-800 number. Might not be 800 now, they changed all that. That's your Medicare representative. Remember how I told you the Department of Transportation likes seniors? Medicare loves seniors. I've had patients where I'll go in and I'll say, what? They say, yeah, they're discharging me tomorrow. I said, you just got here. They said, it's my insurance company. I said, call in the back of the car. I go see another patient, I finish the rounds, I come back in. I'm staying another week, doc, thanks. You know, they're not trying to kick you out. They don't care about length of stay. They're your friend. And if you ever have a question and you don't have somebody right beside you, you tell them, call my representative on the back of my car. If you're in the emergency room and they're telling you that you're gonna be admitted under observation, I've had probably 25 patients say, call my Medicare rep, they get admitted. Okay, no one wants to talk to the rep, because the rep's gonna be on your side 100% of the time. So remember, that's on the back of your Medicare card. And anytime there's any kind of discrepancy and you're in any situation medically, whether it's a clinic, somebody's office, in the hospital, or whatever, if someone's not explaining themselves to you well and you don't understand them, then you say that, please get my Medicare. And that person, wait till you hear, Mary, how you doing? How can I help you out today? What's going on? And they'll listen to every word you say. As soon as you hang up, they call, they come back and say, okay, we're not gonna do X, Y, and Z, or we're gonna now admit you to the hospital. So you have a lot of things on your side, but please guys, the main focus, don't lose sight of, just because you put the POA down and you pick that person because you've known them for 20 years, they need to know you. They need to know what you're thinking, how you're thinking. And also don't forget, that's why one of those things says guardian. If you don't have a power of attorney, or if you don't have someone as that, person that would come in and be the substitute, there are services out there, and I'm pretty sure they're free, that you can get a guardian. I used to run the hospice for Heartland, and we had that a lot of times, where people would get sick, they'd get under the hospice, they didn't have family in town or whatever, so we would give them a guardian, and the guardian then would take care through that whole process and be the power of attorney and be the person to get to know that patient and try to get a feel for what they wanted and didn't want, and they were very helpful. That's available to you. Once again, I don't think you guys will need it, but for anybody you're talking to about it, the ombudsman has all those numbers. So you just get a hold of the Pennsylvania ombudsman and you tell them, look, I need to get some information on a guardian program or whatever else you may need. What they call them, companions, like somebody to just come to sit with you a little bit. Pastors, like there's different places that have the pastors, and it's usually free of charge, guys. Like it's available, but you have to ask for it. So please make sure communication we walk away with today. That's the most important thing, guys. And like I said, I just had the case last night. It happens to me. I'm seeing it more and more frequent now because people aren't prepared for the state of our healthcare. You know, so you go into the hospital with certain expectations, and then you find, like I said, this patient didn't know she could even have a peg tube. You know, so when I inquired through the nurses I knew, the comment was, oh, they thought she was too old. Don't forget Angelo Camerata, 100 years old. That guy was wild. Almost made it on the Leno show with him. All right, guys, any questions? Thanks for having me. Who am I going to blame for being late? Oh, it was the weather. I'll blame the weather. Thanks, guys.